Our next guest, health economist Professor Alex van den Heever, who is the chairperson of the Social Security Systems Administration and Management Study at Wits School of Governance, says when discussing COVID and vaccines that South Africa's dismally slow vaccine acquisition and rollout means the country will effectively have to rely on natural infection to reach herd immunity. With an estimated 150,000 lives lost to COVID-19 already, it's such a botch. South Africa's vaccine delays and COVID lockdown proved deadly, and someone should be fired. Those are the words of my next guest, and it's a pleasure to welcome him on the program. Prof, thanks so much for being with us. Welcome.
Good morning.
So we had a big day yesterday. We saw the president and the deputy president going on a walkabout at the Aspen facilities, looking at all of these vaccines, hearing stories how 300 million doses of the vaccine are going to be packaged there and the bottles filled, and South Africa will get 30 million of those. Did that bring you a little bit of hope?
Well, it did, but what was not made very clear is exactly when the rollout will begin and how many doses we will get at what point in time. So there's still a lot to do, but I think that it's a really positive sign, because I was really concerned about the public statements that Aspen had made earlier in the year, saying they were going to export the entire 300 million doses out of South Africa. And that would have been an absolute scandal.
It would have been. And that's why, you know, in order to actually hear that news, I think that did certainly give us a little bit of hope. Because at the moment, I mean, you know, it's hard to dispute what you're saying, that this rollout has been at a ridiculous pace. I mean, we don't even vaccinate on weekends, whereas when you're living through a deadly pandemic, you should be seeing vaccinations happening all day, all the time, wherever you have these doses available. But suddenly we stop on a weekend, we stop for 4 days, we wait for more to arrive, then they don't arrive. You know, what's gone wrong with this? Do we even have a vaccine rollout? Maybe I should start there.
Well, this current vaccination round is not the rollout. It is an expansion of the existing Johnson & Johnson trial. So it's a workaround because the rollout was not organized in time. It has value in that it's vaccinating frontline health workers at an incredibly low pace. And the doses that we're getting of Johnson & Johnson are not purchased. They're part of basically an access program, part of their available doses for trials. So they've been scrambling around the world to get the doses that are available for trials and diverting them to South Africa as part of a personal, private arrangement. But in essence, that's not a rollout. It's an indication of a weak strategy. But nevertheless, it's very good that people are vaccinated at this point. But it's not our role.
Yeah, that we have to emphasize. I must say, I have spoken to quite a few medical professionals that have received the vaccine, and that is very good news. But there are still hundreds of thousands of others that have not received this vaccine. So one of the things that you said, which is unfortunately looking more and more like a reality unless this rollout actually begins, is that the country will effectively have to rely on natural infection to reach herd immunity. In other words, you don't think that government is ever going to be able to speed up this vaccination process?
Well, I do think that we're in a position now to, depending on just how many doses are being made available, and I'm concerned that there isn't really very strong clarity on that. There are strong noises being made that the Aspen production capability will be about 1 million doses a day, and they will give some part of that to South Africa. But it is unclear exactly at what rate. But I think that we're in a position now to begin to plan to scale up, so that we're vaccinating at about 300,000 people a day. An interim target is about 200,000, but I think South Africa can definitely do 300,000 or even more per day. And we should go for that. That's the kind of level we should be at, and we should have been at from earlier in the year.
Yeah, you are right. I hope that does happen, and I hope that that's the case. But just from hearing a couple of people's experiences that are participating in this trial, it takes some people 2 to 3 to 5 hours when they're sitting in a queue to get vaccinated. And, we see numbers coming through of 10, 15,000 vaccinations a day. How are we possibly going to ever reach 300,000?
So because this is not really the government rollout, at least the full program, and it's really being driven by the people who are running the trials. So they basically expanded against their sort of capability, which is quite limited. But in the full rollout, we have to use both the public and private sector platforms to the full potential. And I think that is a different order of magnitude. So I think we are looking at a completely different arrangement that now despite the fact that we'll probably have some hiccups, that's the kind of scale we have to get to. We are capable of getting to it, and we must get to it. But we can't look at the trial vaccination strategy as an example of what a complete rollout looks like. It's a completely different arrangement.
Yeah, and that is, this is, I suppose, what we need to keep in the back of our mind, but we also need to know when. And that I think is the frustrating part for many South Africans is the when, because we keep reporting that this third wave is coming, in front of it is the fact that we still don't have a set date as to exactly when this national rollout is going to happen. Do you believe that this third wave is going to topple us before we actually even begin the rollout?
So it's difficult to tell. So at this point in time, there isn't any sign of a third wave. And it's also unclear totally. I mean, I've published potential estimates, a range of estimates of the number of people who've been infected to date in South Africa. And it could range from a relatively high amount to a large amount. And that can already provide some immunity, which might diminish the waves in some provinces. But there's still a very large susceptible population that's susceptible to infection, which means that we could have serious waves coming forward. But it's largely the waves are driven by super spreading events. That's clearly what happened in November, December. And therefore there is that risk now. So we know that we have to manage super spreading risks rather than every potential transmission. And if we manage that, we can keep transmission levels at relatively low levels. So the issue is really how do we prevent in these certain high-risk periods super spreading events from driving another wave. Mm-hmm. And I think that's where the caution is going to lie. But there's no sign of a third wave at this point, and it's entirely driven by human behavior. Yeah, and that is good news. And we have been reporting that there is no reason to believe that we are near a third, well, not near, but in a third wave, because the positivity rates are still below 5%. The numbers are looking good, but it also brings into question, however, the whole reporting strategy. And that was something I know you questioned right at the beginning. It got a little bit better in the second wave, but there's still big concerns about underreporting of those that have been infected, which, as you say, could be millions more than we have. And also that death rate. We quoted you in the intro saying at least 150,000 deaths is what you believe we have already encountered. Yeah, so it would be around about 140 to 150,000 deaths that we could have experienced to this point, which is around about 3 times what we're reporting. That is from the excess death estimates, and a lot of countries are starting to look at that. You've seen Mexico adjust their numbers based on the excess death information, and they've adjusted their deaths up by a third. South Africa hasn't actually adjusted its numbers, despite this excess death information having been published by the Medical Research Council for several months now. So that shows we've had a very severe epidemic. And if you extrapolate from that, using an infection fatality rate assumption, it implies that we have many more people infected than would be implied by the reported numbers. I don't necessarily think that means our testing is wrong. It just means that it's quite difficult to pick up all these mild symptomatic and asymptomatic cases in the testing regime. And therefore, but we potentially had a very large number of people infected. But there's quite a range where there's an unknown variable. We don't actually know what the true infection fatality rate is, and therefore the extrapolation of the number of infected people is difficult to determine fully, reliably. But it's going to be a lot larger than what we had reported.
Yeah. Prof, may I ask you, I don't know what your schedule looks like, but do you think we could steal you? We need to unfortunately start wrapping up on SABC2, but carry on SABC News. May I steal 5 minutes from you a little bit later, maybe at about 8:10? Would you be able to chat to us just to talk about a few other issues?
Yes, that should be fine.
Fantastic. All right, Prof, I'm going to just put you on hold for a little bit. We have to quickly take a break. There are a lot more questions, and if you'd like to send in some questions to the Professor, do that now at Morning Live SABC. We'll continue the discussion on SABC News, but let's quickly take a break. That's where we've got to say goodbye. Have a wonderful day, SABC2 viewers. But remember, we'll continue that interview about the vaccine and